but I can give you my word, we will not.
Turn off your cell phones.
For obvious reasons. No. Thank you.
You just turn off the buzzer right here.
Yeah, I will.
Do this.
Oh, she tells.
Is this your?
She tells. She tells the staff. She's like,
It's
yeah.
not worth it.
Okay.
I've already, we go to our ex.
Oh, thank
Yeah,
you.
yeah.
I think.
Right.
They
Yeah.
said bad team player,
Yeah.
so done.
Yeah.
I know, LSW, I know, but
Yeah.
not always gonna come in.
Yeah.
You can talk to them. And Heather, I asked them always. As soon as I asked Robin.
Okay.
Like this.
Is Glenda joining?
Ask Heather, I was like, okay.
Because I will not say anything bad about it.
I know, exactly. And you know Heather.
Barry, you can sit.
Oh,
Let me
feel excited?
Yeah.
I thought you were going to keep me warm. Come on now. Ungrounded.
Yeah, I know that feeling well.
In the air.
I was layer for these.
Yeah.
You never know what you. Okay, we're gonna get started.
Yeah, June,
I'm gonna
Been 8
start
months
with
already.
roll call,
seems like.
just to make
really?
sure we know who's in the room. So for those of
Yeah.
you that are on the phone, hopefully you can hear me. Those of you that are in the room, there should be a microphone near you, and notice there's a little green light on it. And often it's nice to have it turned off until you're speaking, but make sure that you turn it on. If it's on the whole time, all the paper shuffling can be a little distracting to the people on the phone. So those of you on the phone, we're going to do roll call here in the room first, and then we'll call on you by organization to minimize the people talking over each other. So starting at the top, who is here from Amerigroup? Anyone on the phone? Beacon Health? Cascade Medical Center. I see Amy is here. Catholic Charities. We have Chris and Shirley, right? Okay. Hey. Center for Alcohol, Drug and Alcohol Treatment. Is Loretta here? No. Children's Home Society. Blake Edwards, great. Columbia Basin Family Medicine. Columbia Valley Community Health.
Dulcie from Columbia Basin, Dulcie Field from Columbia Basin Health Association.
Okay, thank you, Dulcie.
Yeah.
Got to get the name right. Columbia Valley Community Health.
You got Malcolm and Tim.
Okay. Colville Tribal Health Services. Molly, no. Okay. Confluence Health, I see Rick, I see Tessa. Coordinated Care. Cooley Medical Center.
Actually, this is Molly, and I'm here for Cooley Medical Center and the Colville Tribe.
Oh, good. A twofer. Thank you.
Cool.
Yeah.
Yeah. Thanks.
Family Health Centers. Anyone on the phone? Grant Integrated Services. I think I saw. Yep. Yeah. Lake Chelan Community Hospital. Kevin, oh yay. Mattawa Family Medical Center. Mid Valley Hospital. Molina Health.
Mid Valley Clinic and Tracy Miller are our patient care coordinator.
From Mid Valley, thank you. Molina.
Laura Lee.
And Vicky, Laura Lee and Vicki Evans are here. Moses Lake Community Health.
Sheila Chilton and Brittany are here.
So Kim and Sheila are here. Great. North Valley Hospital.
Clarence Nelson.
Hi, Clarice. Okanagan Behavioral Health. Oh, more from North Valley. Okay. Okanagan Behavioral Health. Jim Novelli and Danielle
Shago.
Chago, the new clinical director, replacing Tenzin, right?
Correct, yes.
Wonderful. Welcome.
Thank you.
Quincy Valley Medical Center. Samaritan Healthcare.
Chris Neff.
Hi, Chris, thank you. Three Rivers Hospital. Okay. I think that's it. Anyone else on the phone that hasn't been announced, please announce yourself. Gwen, I think you're out there.
Caitlin Packard with Amerigroup.
Oh, Caitlin. Hi, Caitlin. The other person?
Gwen from Hollis Health.
Welcome, Gwen. Others on the phone?
This is John McReynolds from North Valley Hospital. I missed my spot there.
Okay, thank you. As others arrive, we'll ask them to announce themselves. Anyone else that hasn't spoken?
And Kathy Rhymes from CCMI CS.
Hi, Kathy. So let's go around the room. Those of you that haven't introduced yourself, I see.
Miller Community Choice.
Carol.
Well, North Central AT.
Very plain, I notice health district.
And I think that pretty much covers everyone in the room. Actually, we had one more person walk in. Thank you. Okay, let's move on. I'll look for a motion to approve the minutes from the last meeting. All in favor? Opposed? Minutes are carried. I have no specific follow-up items from the last meeting, but I did want to make sure that everyone got the email I sent out that said that we've decided to back off of the February 3rd launch date for the kickoff meeting for the learning community. I think it sort of came down to crunch time where, because we hadn't formally announced it, we were a little concerned that the time frame for getting teams organized might be a little late, and that frankly we have a number of logistical items that we felt needed to be tightened up, and so we're pushing that date back, and we'll talk about the schedule a little bit further on in the agenda. So I think this is, I know I've been pushing hard to get this launched because I think people are ready to go, but I think there's another process we need to roll out. I think and we'll talk about what happens in the interim. Okay, everyone got that? So at this point, we want to go through some of those details. Caroline and I have put together a presentation on the proposed structure. We've gone a little bit round and round in the last month or so about the structure in response to a need for clarity around what is the Whole Person Care Collaborative, what are the different roles that are involved in that, how does it relate to the rest of the North Central Accountable Community of Health and the other projects. So we've worked pretty hard to try and clarify that and come up with a structure and a process that makes sense. So hopefully you've had a chance to read it. Caroline and I are going to go through this and also go through the timeline and the funding proposal in the next hour. So I think we've got enough time to take questions and to have a conversation, but we'll see how this goes. Any comments or questions before we start? Barry.
Am I right in thinking that, if possible, coming to agreement on this and recommending it to the governing board along with the related charter?
Yes. That would be really good. And I'm not sure if the board would approve it at today's meeting, but let's see how it goes. I think getting the endorsement of this group would be a a good step. And I realize that we've taken on a lot with this collaborative, and we've thrown out a lot of terms. So if you've been confused, you know, our apologies. But I think it is complex what we're taking on, and we're working hard to clarify it as best we can. So with that, Caroline, do you want to take it away? Go off of that slide. Notice that the learning community slide below the whole person care has corollaries in the others. Transitional care and diversion doesn't have a dark box there. It has a TBD, but we're assuming that there will be a process similar to the whole person care collaborative, where we'll be rolling out, some sort of a proposal process where we'll be soliciting input from groups, probably, so that we will have something similar to the whole person care learning community. It's just that, we're ahead of the game in, funding and getting this project operationalized, but the others will be coming along as well. Just wanted to clarify that. Yeah, let's see, more or less this group, but we want to refocus it to the clear focus that sounding board.
Peter,
Sorry, I didn't have my mic.
mic on.
Yeah, okay. Sorry, thanks, Sheila. What I mentioned is that the work group is more or less this group, but we want to refine the membership, we want to clarify the role, and we want to use that group as a sounding board, not just in the monthly meetings, but perhaps in between, to reduce some of the cycle time on decisions that would allow us to move a little more quickly. And obviously, the big decisions are reserved for the board, but as we move from sort of a strategic phase into a more operational phase, I think we're going to need people on this group that are definitely operationally focused, that are tied to improvement efforts in their organizations, that are tied to the quality improvement people or are the quality improvement people in their organizations that can help drive this. So.
This is Rick Horgan. I just had going through the eligibility, and this, I mean, passed me by earlier in the year when we did the charter, but I'm a little concerned by 500 encounters. I think that, especially when we go to the funding, 500 encounters, you could, I mean, to be honest, and this would be overuse, and I don't think anybody would be at this level, but a provider who saw one person weekly,
yeah,
whether it be counseling or something like that, 10 members would qualify them for the funding and everything else. And I'm wondering if we shouldn't add a number of unique members seen plus encounters as a qualifying criteria, because I would hate to not foresee what we're actually doing and have some unforeseen consequences.
Okay, comments on that?
My concern would be Children's Home Society of Washington would be just shy of unique client survey.
Oh, I don't think that's be 500 members, 500 unique. But some number of unique plus number of served. Does that make sense? Some formula different other than just 500 total encounters.
So what I hear is maybe something like a minimum of 100 unique patients and/or
and 500 maybe. I don't know. I don't know where that we'd have to look at people's numbers, but I'm just concerned that. So, and I don't know where your numbers would lead you to that. I think that's important to know. Is like so if we said unique members, what's an idea for how many unique members you serve?
Served annually.
Yeah.
Just shy of 500, literally.
Okay.
475.
Yeah, so that I think you'd easily make it with that. I don't think we have to have 500 unique members served, but what David, some sort of. So I'm guessing with that you had well over probably 2,000 encounters.
About 6,000.
Yeah, see,
would be our projection.
Right. So that's 6 a member. What if someone saw someone weekly? Is what I want to get away from. Is that bottom number of. I serve 10 members and I qualify for $100,000 in funding.
Absolutely. Just want to make sure.
Yeah. No. Okay.
Any other comments on that?
Peter, can I ask specifically, in the charter, where are we? I must be missing this in the charter.
What page?
Eligibility.
It's it's on the first page of the Learning Community Charter. Yeah, second bullet under eligibility. So, yeah, I'm sorry that we haven't.
I got it.
Okay. So could I hear a specific proposal then for an either or, something like, 350 uniques or 400 uniques with. So
we're being random here.
We are being random, yes.
We're being random. I guess I would want to make sure that we know as a group who we would like included in this learning community and build the eligibility so that we're not leaving someone out, and we're not just randomly throwing numbers out, because I don't know everyone's level of service around the area. So there might be someone in the room that we've randomly changed this eligibility to that we leave out, maybe that's not participating today.
Okay.
So where
Fine.
where would this leave the individual behavioral health providers that don't have those numbers, that do see some Medicaid or Medicare population?
Probably they wouldn't qualify.
Saying that there's a number of them in this North Central that see together see a lot of our patients.
Yeah.
Right, no, and I think there needs to be some sort of number there, but you've got to be serving some sort of a population of some number, and I don't know what that number is, but I just can't, we don't have the funds to do everybody at every level, just because you have one member that you see, or 10 members that you see. So we need to look at the breakdown. Do we have those numbers from the state?
Yeah, we do have the numbers, and actually we've circulated some tables here before, both of encounters and of unique members, so we've been through this, but we haven't gone down to the very, very, very small numbers. I think we cut it off at about this level.
And maybe that works.
Yeah.
I don't know, but
Yeah, I mean, the point I think that Rick brought up before is there's a proposal later today, you know, that each organization will get a $50,000 block grant and then additional funding based on the, you know, what they're actually doing. And I agree, a single practitioner in solo practice getting a $50,000 block grant is very different than Confluence Health getting a $50,000 block grant. So it does make sense to me that it is a significant provider. And I guess, yeah, if we can look at those numbers, and if somebody could come back and make a recommendation to us as to what the number of unique lives and total encounters would be, I think that'd be helpful. I would trust members of the board to do that.
Well, I was going to make a process suggestion to Malcolm, and because what's been happening is, you know, as things get tweaked, every time we do that, we go through another month-long cycle, and we're really trying to get to the point where we can move ahead. So I can't speak for the whole board, but what if the proposal was simply that the board would entrust the work group to set a reasonable threshold to assure that those involved serve a significant volume of Medicaid beneficiaries, and then, you know, so that we're not waiting yet another month for the board to say yes, and that, I mean, this group's going to be entrusted with allocating a lot of money already. I don't think that, you know, we couldn't do that. So just change the language a little bit to say, to leave out the specifics and say threshold to be defined by the work group. Because Sheila's right, we don't, you know, we should do it based on data, not a guess.
Defined by the work group prior to something. That is
Well, I would prior to establishing awards.
Yeah, that's
Yeah. Oh, you're right. In advance of award, not after. Not make up the rules as we go. Yeah.
I think I see it, isn't it a budgeting issue? We have, what, around 40 million for 2018 we're working with here, and somebody like, you know, if you've looked at some of these graphs that just mentioned, Children's Home Society of Washington would be a point of reference at the very bottom in terms of data, so that's a good point of reference. End of Q1 2018, $50,000 block grant you mentioned for a change planning award. End of Q3, an additional 2 payouts. Children's Home Society, that quintillion, whatever that means, award would be $40,000 plus $20,000 based on percentage of Medicaid served. That puts Children's Home Society at $110,000. Then we look at all the agencies getting payouts in 2018, and then it becomes a little bit of a budgeting issue.
Yeah, and, you know, part of the reason that we're not, you know, launching immediately is that the board hasn't actually approved, you know, an allocation to the Whole Person Care Collaborative, as well as all the other things. So we've got a global budget we have to set, and then whatever we set, this process has to live within it. So you're right.
Okay.
And I have to say, it's up to 40 million for the whole 4 years, not just for 2018. I wish it was.
For all the projects.
For everything for 4 years.
For all the
right.
projects, yeah.
Yeah.
And so again, the point being 110,000 just for the smallest organization.
No, I hear you.
Yeah.
You're right, it is a budget issue too.
And John, you have a comment? Okay.
Yeah, thank you.
We wish you were right.
Yeah.
Talking too fast.
You got him worried.
So are people okay with that modification? We would just strike out the things in the parens and replace it with to be determined by the work group prior to contract awards.
So moved.
Second.
All in favor of that?
Aye.
Okay, thank you. I think we do have an issue to address, which is, as Ton brought up, I mean, there are a lot of people out there that, you know, will not be eligible for funding, and I think that's understandable. We have to titrate this in a way that gets maximum, you know, maximum exposure. But I think the processes that come out of this should live in the public domain, and I think we need to find a way to reach out to providers at large so that you know others could benefit as well. So I don't have an answer to that, but I want to acknowledge that that's an issue. Okay, other comments, other questions?
Peter, on the
Sheila, go
I have
ahead.
a question on the work group charter then.
Yes.
So there's a lot of mushing of papers. I'm having a hard time hearing.
Okay.
Their charge says that the work group was tasked with providing oversight. And since this is going to be our charter going forward, could we change that to say that the work group is tasked with providing oversight? That would be one suggestion rather than speaking in the past tense. And then I would also like to recommend under composition that we just say a WPCC work group chair will be appointed. Just to be consistent, because down in the section under meetings, we talk about what the work group chair shall be responsible for. So just having some consistent language there are my recommendations to that charter.
I wasn't on the right page, but I'm wondering if someone else got those. So I got the is task, and the next one was
Under composition,
next page.
in the second paragraph, second sentence, that a work group chair will be appointed.
Will be. I mean, is that? I mean, do we want to be? Are we certain that we want a chair? I think we want to leave open the the possibility. That's the way it is in the others.
One word, and changed it to may, just for the very reason Peter explained. It kind of gives some flexibility there.
We weren't sure we could recruit anyone to be the chair, so.
That is
So
true.
it's not that there wouldn't be anybody in charge, but that sometimes staff support is adequate for a work group, and sometimes it needs its own chair, and this just makes it optional. And the idea is that the other charters might be adapted in the same way.
But I mean, this
But
this
yeah.
this is at the pleasure of the group. I think what we're trying to do is bring some clarity and accountability to the group to make sure that it has oversight, that this really is run by the group and it's not just staff driving this. And if we had a chair and a strong group of members, that, you know, as the director here, that would serve my needs. I would like that personally. But what's the pleasure of the group?
I personally think that leaving it with the May gives more flexibility around the model.
I agree. I think that, at least speaking from my perspective, raising my hand to say I'll be a chairperson right now is completely out of the question. So I think if we leave it as May, we may be able to work in a way that we get commitment from people. So
I saw Chris Davis nodding. Was that you wanted to be the chair or
no.
the?
Agreeing with Gail.
That's what you just whispered to me.
Yeah, I heard that too.
Okay, so Sheila, I think the group is sounding like they want to leave it as May, and that doesn't preclude us creating a chair at some point, and we can rediscuss that.
How about to Sheila's first point, that the work group is tasked with providing oversight? I'm fine with that.
So other changes? So could I have a motion to adopt the first of Sheila's suggestions and not the second?
So moved.
All in favor?
Aye.
Aye.
Opposed? Okay, that's carried. So where are we now?
Well, you want the group to approve the newly formatted.
Yes, yeah, okay. I thought that's what we did as,
Oh, okay, so I thought you were just approving those changes.
I think we just approved Sheila's.
okay. So, so I would entertain motions then to approve the charters.
I move that we accept the whole person collaborative and the whole person learning community charters with revisions.
Work group and learning.
Second.
Further discussion. Okay, hearing none, all in favor?
Aye.
Opposed? Okay, so we have the charters recommended to the board for approval. So thank you all. I think that's, hopefully you'll agree this provides a lot of the clarification that we were looking for. I think one of the next tasks is going to be solicit volunteers from that composition table to serve on the work group. And as I mentioned, I think it would be great. You know, I think we've got a good group here, but to the extent that you think someone else in your organization might be better positioned because of their, you know, operational knowledge and so forth, as long as you've got, you know, good oversight of that, you're comfortable with, you know, that these things are understood by the, you know, the top levels of the organization, having some operational representation, I think would be helpful. So we will solicit that from you and ask you to, you know, step forward, not right now in public, but to ping all of you for who might be interested or willing to do this. Okay.
I guess I have a question. If CVCH wanted to have 20 people participate and Confluence wanted to have 30 people participate, things might get a little unwieldy. So do we want to, you want to give us some guidelines about number of people from an organization or any other suggestions?
Are you talking about the work group specifically, right?
Yeah. This.
I was thinking of one per organization, but not necessarily one just for primary care. So I think we could have, I think it would be good, for example, to have you know, representation from, you know, the FQHCs, from the hospital group, from Confluence, you know, in some way that, you know, mirrors the board, but I wouldn't look for more than one person per organization to be on the work group.
I'm gonna just say, I don't think that's probably adequate when you have diverse organizations like that do a lot of behavioral health and do a lot of primary care and do hospital, and, you know, I think that you're limiting the input because some organizations are too big to have full scope, one person to have full scope.
I agree with that, Rick. I would suggest that it would be an organization that's representing is represented at the work group, and it's up to the organization if they want to send 15 or 20, but it's still one vote. But it's input, it's a dialogue that can occur, depending on how the organization wants to, you know, get their opinions or express their views at that work group. But it's still one vote. That's my perspective.
Other comments? I understand the concern, and I also think that it's important to have a small and nimble enough group that you can actually schedule meetings and get consistent feedback. I think one of the challenges we have here is that we're very diverse, which is good because we get a lot of different opinions. But when it comes down to making, you know, operational recommendations and so forth, and we need feedback in between meetings, I think I was envisioning would have, you know, 6 or 8 people who would speak for the work group who could, you know, help advise us. And if it's 20, I think that makes it a little unwieldy as a work group.
Just from my perspective, thinking about it as a board member, one of my concerns is when you have that many people involved, each time you take a vote, it's like whoever happened to show up that day. And that person might not have showed up 2 out of the 3 of the last meeting. And you just don't have a continuity of knowledge that produces adequate decision making. One of the challenges we thought a lot about too, and, you know, putting the board together is, you know, it has to be big enough to have some reasonable level of representation, but at the same time small enough to be accountable and make decisions and that sort of thing. So, I think that's the intention of the body we're talking about, is that this would be the decision-making group for what the whole learning network does, whole person care learning.
Well, then I would argue that it's really a matter of process. That the agenda or the information that the work group is going to be deliberating is sent out to the organizations in advance, so that the organizations can then internally have discussion around those topics, and then go to the work group representing the voice of that organization.
Yeah, let's hold this, and as Caroline suggested, go through the remainder of this and see where we come out. But Tim, I don't disagree with what you said. I think that's the ideal, is that we would have materials in advance and organizations would have the opportunity to vet them. I think one of the challenges we always have, particularly with large organizations, is that you know, who really does speak for that organization, and do they have time and the structure to actually vet those things internally? And that, you know, that can be hard. I mean, Rick, I'm looking at you and thinking, you know, you carry a fairly large burden to represent Confluence Health.
And I can't and I won't.
Yeah.
So.
He already hurt his arm because of that.
Yeah.
You put that on record too.
So let's see if we can wrestle with that that discontinuity here and go through the rest of this. So
good discussion.
Okay. All right. So what we want to do now is walk through some of these, you know, process slides. Talk about the work plan for the work group over the next couple of months. So.
So it's really what's on the horizon. So real quick, I wanted to share what our timeline, not just for the collaborative work group,
are looking at April, that's our own deadline. But then the two September deadlines there are, they're predetermined by each state. So those are kind of like bookends that are requiring us quickly over the next 8 months. And again, I shared these slides in December, I want to remind you that this is how the Medicaid demonstration is in terms of walking through. The great thing is that we are moving but there's certain milestones that are that we're going to report up today. And some of the key questions that we need to reconcile stages here we our other work group. And actually some of the in our other work group. So there's a little bit of work off. You're ready to start the next but haven't worked out all questions that you we're close, but they're not all spelled out. So we're grappling with clear funding for us. One of the things in stage one that other work we're working on and
Yeah, we're gonna have to speed through, but I think the point here is that you know, we've got these evidence-based approaches that were outlined in the toolkit, but as you'll see in the schedule, it would be good if we were to drive a little bit more specificity down into our change plan template. That is, if we look at all of the things we're trying to accomplish, you know, we could use some time between now and the delayed kickoff to get some more specificity in there. I think that's.
So for the work group,
So, you know, here we are in January. We, you know, getting the charters approved would be great. I think we just did that. You know, forming the work group, getting the board to approve the members, getting feedback, which we hope to do today on the funding for stage 2, and then you know, looking at change plan evaluation options. So this is all part of funding. It's, you know, doing a collaborative is one thing, but tying all of the you know, funding requirements and so forth of the HCA to that is what I think is creating some complexity for us. And we want to do it right. We want to make sure that, you know, as we heard in the room, that we're, you know, we're fair to both big and small, and that we maximize the way the funds are being spent or optimize the funds. So in February, we're looking at, you know, getting the stage 2 funding to the board at the next board meeting. You know, getting some of the infrastructure around the portal set up, and then fine-tuning the change plan template to make sure that we've got enough detail in there for people to, you know, really dive into. I think a number of you are already working on it. That's great. There's nothing that should hold you back. But in terms of what specifically we would be looking for in each of those elements, I think we could probably improve. March, we're thinking the portal would be unveiled. We would have done some legwork on setting it all up, and that at this point we're looking actually to have the kickoff meeting in March. This internally we haven't finalized, but that's when we would do it. April would be you know, looking at stage 2 contracting. That is, you know, exactly what would the contracts look like. We would continue to do that into May. June, we would, you you know, this is stuff we would be working on, you know, to make sure that we got our project plans aligned for the HCA timeline. In July, we would continue the process of developing the change plans and actually, you know, continuing the reporting and the, you know, the reporting and measuring part of that. And then in August, we would, you know, sign off on change plan results. This is the work group. Remember, we'll talk about the learning community next. But this is the work group's work of signing off on the process, making sure that it's all working. So let's go to the yeah. Let's go to the learning community.
I'm here. Thanks, Caroline. So on the screen, you see the 8 primary area of the change plan. And again, you'll notice that they correlate with the projects that are required from the state. And the idea, again, is that organizations will contribute what is appropriate to their particular entity in each of these areas. What we'd like to do is to tie the change plan components to some changes, what Peter just mentioned, some detail that's underneath each of these categories. And by so doing, we can set those up on the portal so that it makes it easier for teams to report. So in other words, if you're addressing the opioid epidemic and we've got a primary care provider, maybe they are going to work with clinicians about prescriptions for acute pain. So that type of change would be available in the reporting template so that it would be merely, that's what we're working on, click the box. In the same way, a behavioral health organization may be working on expanding their substance use services, substance use disorder services, I should say. And so they may have something easy to actually check that box. The idea is that the change plan will link via the HCA toolkit with all of the changes that they recommend to the reporting system so that everything flows, all of the contributions that the teams are making individually will roll up and we'll be able to see what the teams are working on. And if all of the teams are doing good work and meeting their milestones, we should also be able to see the result of all of that work in our measures. So that's the other reporting component that all of you will want to see, and that's the measures that are required by the agency. So the change plan and the report, most of us call it a narrative report because it's more qualitative. What are the teams actually doing? And then the actual data reporting. All of those should tie together. And then the work group's job and all of you in the room should be able to monitor the progress of the overall initiative toward the goals that you set for the accountable community, your accountable community. So let me see if there are questions there, just trying to, at a high level, trying to relate those and to explain why those particular areas were chosen. That's up to the group.
Kathy, I think people are pretty familiar with, you know, how those things were chosen because they tie to the demonstration project, you know, projects and goals coming out of that. I think maybe the questions might be around the monitoring. Other, Blake, you look like you have a question.
The last change thing, everywhere else.
It should be both, yeah, yeah. I mean, access is access, and if we've limited to primary care, that's,
Allowable on the
yes.
board.
And again, just for clarification, we chose 6 projects, but then we've included addresses social determinants of health and improves access to care. Those are not projects we've accepted, but I guess we're saying that these are linked to our ability to achieve the projects. Is that how we included those?
Yeah.
Okay.
Yeah, they tie directly back to the HCA goals. So they were felt to be significant enough in driving the overall improvement toward the metrics that you're trying to accomplish, that they were included here just as added emphasis. And also, those 2 areas will be a great opportunity to link with your community-based organizations as well.
Right.
And so some of what we would expect to see in the change plan are the linkages that many of the organizations that we saw during our site visits are already trying to accomplish. So we know that patients are in our systems for very, very limited periods of time, but they're out in the community a lot. And so trying to provide linkages and ongoing resources and support for people when they're actually not in our behavioral health or primary care office will be part of this work.
Other questions? Okay, should we pivot then to the timeline? Let's go through one by one. So we were talking about the work group before. Now we're talking about the learning community and the activities here. So this is what we're thinking, and your questions and critique is important. Approving the charter, we've done that. Getting MOU agreements signed for stage 1 and awarding funding, we think that's a January or perhaps early February kind of thing. But getting the money out, making sure everyone's in, should be this month or early next month activity. Secondly, funding awards continued, and then given that we would have a little bit more time before the kickoff, I think it's an opportunity to do a certain amount of pre-work. And what I'm thinking is that we as staff need to do a little bit more of one-on-one outreach to each organization to look at team formation, change plan, pre-work. That is, where are you in the realm of thinking about the change plan, your priorities, looking at development priorities. That is, what sort of supports might you need in order to get involved or make the decision to join. And then identifying training assets. That is, who are the people in your organization? Who are the faculty that we might recruit, both from inside and outside the region, that could help us in the learning activities once they're launched. So there'll be a lot of work to be done. March, we would do the kickoff. And Kathy's going to talk a little bit after this about what the agenda for the kickoff meeting would be. We would open the portal. That is, some of that pre-work would also probably be done in February to get that thing up and running. And then the final whatever change plan would be released at that point. So at this point, we would have populated it with more evidence-based guidelines and more refined instruction for all of you. And this is with your input, by the way. I'm looking for help to do that. Then in April, the learning activities would begin. We would, come out of the kickoff meeting with a clear idea of what learning activities, how many teams, who all would be involved. So that would start. In May, we would continue the learning activities. June, we would have some sort of a quarterly convening and continue the activities. July, we would look for final submission of the change plan. So we would have still 4 months between the kickoff and the completion of the change plans. And remember, the idea was that the learning activities would be designed to help us refine the change plans in order for them to be submitted in July. The original, we said we'd have them done in June, so we're moving it all back a month. And then,
Excuse me, Peter, what's the advantage to submitting the change plans through the portal? I mean, is that just, that's the email we send it to, or? When we submit new information, it updates it.
Yeah.
You then just forward that to HCA or something.
yeah, I mean, this isn't a drop dead commitment, but this is what we're thinking of. And this is really to make it easier for you if you've got, web-based fillable kind of change plan. It makes it a little more dynamic, a little bit easier to manage than, piles of paper. So that's what we're thinking there.
So it's the work group, but it's the learning community that's going to be making recommendations to the board on
No, that would be the work group.
the work group. Now look at the work group for that. And I don't see where that's February. Basically, look, that's the funding model that you've got to work. But I don't see I'm going to finalize template evaluation. That happens in February for the work group. Then
Yes.
sees the March
Yeah.
learning plan.
Provide input, fine tune, finalize, change plan template. Right. Okay. Yeah, we want the work group to be the policy setting, the oversight body, and then the learning community is the executor. Okay?
So where would the MOU formulation?
Yeah. No, that should be the question was, Rachel brought up, she doesn't see the finalization of the MOU on the work group timeline. And I'm not sure what our thinking was, Caroline. But I think technically you're right, that the work group should approve the MOU. Yeah.
And then just one other question, the July, in July, the,
Yes, yeah, we're moving it back to July. It still meets the HCA deadlines for getting that done, and it's still with a March launch, gives us 4 months to complete that. Good questions. Rick, you have a puzzled look on your face.
after I dumped it on the floor. I think as these are documents that are out there and people are looking at, perhaps maybe what would help is one, changing the colors between the two different timelines because it's going to get very confusing, but also integrating them. So you can have January, you know, in blue like it is for the work group, and then in yellow or orange underneath it for the learning community.
Yeah.
And integrate these so people understand the flow in between them. Because I mean, I felt myself getting confused as we were going back and forth, and just perhaps as we get that out there and other members are coming on who maybe aren't as involved, it might help.
Good questions and good suggestions. Thank you. I mean, we're trying to provide specificity. We're trying to make this no more confusing than it needs to be, but you know, I think we're getting close. And thanks to Caroline for all of the the thinking that she's done around this is really helpful. Okay, so we're back to August. This is when the change plans would be evaluated. Remember, we're looking back to the work group, to oversee the evaluation process. We can talk a little bit more about that later, and I want to talk about it when we pivot to the funding proposal. Okay, are you exhausted, Ton? I think they should start working now on their plans because we will add more specificity, but I think we agreed on the framework, and that, doing some pre-work or thinking and getting going on the planning is a good idea.
Peter, could you repeat?
The question that Ton raised was, would we recommend that teams wait until the change plan is completely finalized to begin their work? And I'm suggesting not. That the framework is there, we will add specificity, but we're not going to take any of the categories out at this point. I think we're pretty well dialed in on what the work is, but how exactly the work would be done, I think we'll continue to refine.
I might be stretching this, and if I am, please let me know. But I think what might be implied in the question is also the baseline time period, and so that if you start it now, and then you're not going to be getting credit necessarily for the good work that you've done. That's really about the demonstration outcomes. I mean, obviously, some of the work you want to do anyways, but really the baseline period, and then so making sure that's established prior to the work, and then we can get credit for the work that we're doing in the demonstration period.
John, can you comment on the baseline? I think that question's come up before, and I don't see it as a problem, but I know that this question of if we started early, does our baseline change, and therefore we don't get credit? Most of what we're going to be doing, and while John is reloading here, is going to be P for R, so P for reporting, really up through the next couple of years. So, we're actually going to be incentivizing you around developing the change plan and then executing the change plan. So I don't see any problems in getting started sooner.
I think the assumption is that you're going to continue to make progress and improve, right? You're not going to fulfill it this last year and take credit for all that for the next 2 or 3 years. And so all it really is process specific for the first few years. And so as long as you're making processes, we can take that information, we can report it up. When it comes to like pay for performance, Healthcare Authority has dates of tracking and ways to account that to the region, and we're going to come up with a method as a region to figure out how those funds get distributed, but I don't know that wouldn't be a concern for your original question. So I think you're fine. It might be, I think part of the sticking point is you're thinking, can you get retroactively reimbursed for the work you did, or am I making that up?
It would be an example, like let's say we sign an interagency agreement with someone else. Now, like in February, would that still count if we're doing the change plan that it's not submitted till July? Like, because we're working on, bi-directional integration, and then but you're doing it right now, and you're not going to actually submit your change plan until this February. Like, will that count? Or is that baseline?
You're asking about a plan that you're already going to have earlier than the deadline for the plan. I haven't seen anything in the criteria about when the plan is written. I don't think anybody's going to say that's a 3-month-old plan and we don't want it. The other part of it is that the granularity of the pay for performance that's going to be underway for the first couple of years. I'm sorry, pay for reporting as opposed to performance isn't so fine that if you tweak it a little in 2018, you're going to get punished later compared to somebody else. The state has these metrics. 2018, based mainly on Medicaid data. 2018 is going to be the baseline for that, and then we'll get judged. But we won't even start seeing any implications from changes between 18 and 19 until 20 and 21. So, it's not going to be like you said we were going to do 5 of these things, and you did 2 of them before the start of the contract, so you're going to get penalized compared to somebody who didn't start early. I don't think that's going to be the dynamic. I just don't think the granularity is that fine.
I think I agree with Barry on that. I think it'll just strengthen your change plan to list what you've been working on and where you plan to go. And that's really what it's about. It's not, I guess someone from the team quote me if I'm wrong, it's not 100% that everyone has 10 things that they have to complete, and every individual has to complete these 10 things. There's a uniqueness to each organization based on where they're starting, and that's where it comes into play.
So I just want to comment and say that the pay for performance part of this is a little up in the air, and the original intent for this was to say we are going to be judged on pay for performance, in the out years. The HCA doesn't have a way of attributing that down to the individual provider level. We get into some very small numbers and some, some issues around confidentiality of data. We probably need to do an in-service here at some point on, exactly how the HCA envisions this will work and how we would translate it into our own process. But for the time being, I think we should focus on process, pay for reporting. In other words, coming up with change plans, having agreements around executing to those change plans, and that's where our focus should be, because we can measure that, and we know that our performance ultimately will be tied to the implementation of those change plans. So that's where I think we should focus. Hope that's helpful. I would like Caroline to pivot to the funding proposal, because we're a little bit over time, and I want to save time, Kathy, for you to talk about the kickoff. But we have some important considerations on funding that we would like to go over. And I know that this has been one of the tougher parts of this whole thing, is to figure out how we roll the money out, not for the initial funding, but for the stage 2. So I just wanted to be clear that what I've outlined in here is just clarifying where we are on funding for stage 1. So Caroline, if stage 1, again, the intent is to create a relatively low bar. We've already talked about $75,000 plus a tiered payment depending on the number of Medicaid encounters that you have. So that's stage 1. Is there any lack of clarity around that? Are we all good with how that's going to work? This was approved a long time ago, and I think we just need to execute it. So that would be done with MOU signing at the end of this month. Okay? Are we good with that? So
do we have any idea of what that works out to be?
Yeah, I think it's about, let's say, 17 organizations, average $100,000 each. So that's, a million, 1.5 to 2 million, something like that. It's in that ballpark. Yeah.
But some of that was.
Not for stage one, right?
Not for stage.
Yeah, this is stage one.
Yeah.
That's all right. So stage one, we're good. No longer confusion on that. Good. Stage two, after discussions with a number of people, there's a proposal on the table to pay based on two factors. One would be the size and complexity of the organizations involved, and the second would be the quality and comprehensiveness of the plan submitted. And remember, the original one just had points for all these things, but we hadn't really figured out how we were going to adjudicate that. And we didn't really control for the size of the organization. So on the size and complexity, actually we can skip through the table. I mean, there are a number of different ways we could do it, everywhere from flat funding to number of providers, number of Medicaid encounters, the whole thing. What I'm enamored of and would like to try and sell is, let's skip to the proposal here, which would be to fund based on the number of teams involved, so that every organization would have some base payment, would be the same. And I've got a table here that's, it's got arbitrary numbers in it, but it gives you an idea of how the math would work. And then we would give an enhancement for each team. So what we did was to look at, okay, what's a team? It's got 5 people in it, and we've talked about a clinical lead. We've talked about a senior leader who kicks it off. We've talked about some frontline staff. Anyway, a team of 5 or so people who would be your implementation team. And we would give a certain amount of money for each team for each learning activity. So this is making it scalable. So you would have fixed component, you'd have amount per team and amount per learning activity. So the idea here is, you pay to play. And what I like about it is we want to maximize or optimize the spread of this change, throughout the region. And change happens at a very local level. It happens at a team. And to the extent that we can, do it based on teams, you're a small organization, you have one team, you're not disadvantaged. But if you're a large organization and you have the capacity to involve more teams, you get the benefit of it. And the ACH gets the benefit because we're spreading those processes to more and more providers and more teams. So that's the notion here. And we can titrate the numbers to make sure that it fits in our budget. And we would have to set some limit, I'm sure, on the number of teams a particular organization could send. But the idea would be that you wouldn't be disadvantaged if you're Confluence. You could send more teams, or others that have multiple clinics that want to send them. So reaction to that.
Question first.
Yeah.
To be clear on the language here, when you're referring to team, are you tying this to the demonstration project? Is that what you're saying by team?
Yeah, the question came up is, does this tie to team as an organization would define it? I'm using team as what CCMI and CSI defined a team. That is a group of people who work together, a multidisciplinary team who work together. Literally, they're from the same work environment, who are participating in a learning activity. Same locale, people that know each other, work together, because they're actually going to be working on processes that they're involved in on a database. This is not hypothetical. They're going to take these learning activities, go back into their environment, and do these PDCA cycles.
Just a quick recommendation for the future. Maybe we're adding more nomenclature into the process, and maybe helpful to have just a working definition because we're moving into learning activities and teams, and there's demonstration projects. And again, I just think that if we can get a standard language around some of these things, it feels like my brain kind of jumps around. I'm not sure what part of the process we're talking about.
Okay. Is that, so I think we need to be clear what a team is. Yeah.
Right.
Yeah. Yeah, just to clarify, the learning activities went back to the original proposal that CCMI and CSI came up with. It listed a whole bunch of different things that we could do. There were various kinds of learning activities at different intensity and duration, and so we'll resurface that. And the intent was that we would decide what kinds of learning activities and what topics they covered at the kickoff meeting.
I just didn't know we adopted the language. I know that those came up at one point. It's just hard to connect it into kind of the working language that we want to use on a continuous basis. Points be made.
We're gonna miss you, Tim.
And do you have a max number on this? You give examples. Speaker. You give examples. I just want to make sure, are we saying like, well, I've got 20 teams. You know, I'm just hoping that we set some sort of a level there.
I would think that 10 would be the absolute max, but it might even be less than that. We would have to, but it's not 20.
Right.
So of the 4 models that were mentioned on the previous page in the handout, essentially there's a recommendation to use model number 4.
I think it's a blended model actually, because it has a fixed component to it, and then it's got a variable component. So it would be blended.
So I would ask the question, if we used a blended model for stage 1, which was part fixed and part based on the number of encounters, I think, why would we do something different for this? Why wouldn't we have a fixed amount and then something based on, I'm assuming, Medicaid enrollees, either the number of lives or the number of encounters? That received approval. I'm not sure why we're doing something different.
Let me take a crack at that one. The reason is that when you get to the implementation stage, you're talking about what the organization will actually do, where the rubber meets the road at the level of care delivery. And that's a question of how many care sites will contribute, how many teams of people who work together there to do specific learning activities. So it isn't just a question of how many Medicaid lives you address, but what are you planning to do about it? And how many of those things are you planning to do? And from how many care sites are you providing a team? The difference between the planning stage, where things are pretty undefined about what you're going to try to do, and the implementation stage is that in implementation, it should be pretty well defined what you're going to do. And the more you're going to do, the more you should get paid. You may, if you serve half the Medicaid population, but you're going to have one team doing 2 learning activities, that's what you should get funded for.
Okay, well, my counter to that would be CDCH could play the game and have as many teams as possible, go into as many things as possible, but all they do is they go to the learning activities. There's nothing there's nothing that requires that we implement this. And I guess, to be fair, there's just because we have X number of encounters, there's nothing that requires us to implement the things. I'm just, I'm struggling with paying for participating, but you're not participating in care, you're participating in going to classes or sharing information. I'm struggling with that.
Well, I don't think that's an accurate description,
Can I
David,
respond to
of
that?
what, yeah, of what it would be.
Yeah.
Okay.
I mean, I think it's a good question, but I don't think what we're suggesting is they're just going to classes and learning. That each team would be reporting progress through the portal. We would be monitoring improvement and performance for each team, not just each organization. So, I mean, the intent here is that these learning activities are helpful to you. Okay, that if you're, I mean, this is the whole premise here is that we're helping you, providing incentives and training and all this sort of thing to help you get where you want to go faster than you would otherwise. That's the intent. If we're not doing that, then we need to ask ourselves what we're doing. But the more teams that are involved, the more joint learning there is, and we're actually saying, we want to give you money for your teams to participate in this because we think they'll benefit and you'll benefit from it. So if that's not happening, then we've got a problem in design here. But that's the intent.
Well, there'll also be a lot of feedback coming in. Go ahead.
No, I'm just in to address David's part. I get where you're coming from, David. So maybe you just say we don't pay the base amount. Then you're only paying for the team to actually be doing learning activities. We already have a base amount that we're paying everybody up front for the stage one. So I'm just, if you change the formula that way, it would address David's concern, which I think is legitimate, but I mean, I see both sides.
But this might be a matter of definition again.
Yeah.
Because when you say learning activity, is it a matter of attendance or if it's actually doing something around what that activity includes?
My assumption is it's doing something around that activity.
Yeah.
Kathy, could you comment on that? Because I think you'd be the best one.
Sure. So the learning activities are designed so that there has to be not a passive process at all. And so you will be sharing the changes that you're making on the ground within your site and also the process outcomes that you achieve. So the learning activities differ in their intensity, pacing, and their scope, but they all require transparent and active participation because, and the rationale for that is so that we can spread that learning peer-to-peer in a step-by-step way to actually enhance the improvement.
Well, then that's different than what I was assuming. So if one of our teams makes a presentation and gives updates about, the results or whatever, that's participating. If someone comes to a meeting and hears that, is that participating as well, or is the participation the presenter and the presentation of information?
Well, I mean, I'm not sure I understand the question, but I think participation is the whole thing. It's attending the learning sessions. It's coming up with interventions or improvements. It's testing those improvements. It's reporting on the results. And then it's going back, in standard, quality improvement language, doing, plan, do, check, act cycles, and continuing that improvement over the course of time. And so there's learning, there's doing, there's adjusting, and presumably if we do this all together in a very transparent area, we're learning from each other and we're spreading, best practices throughout the region.
So reporting on an activity and receipt of the information from that report are both qualify as a learning activity.
Yes. Kathy, would you embellish that? Anything more you would say?
We might have lost her.
Oh, we lost her.
Good. She might have just rejoined.
Okay. But, I mean, a number of you have gone. So, Kathy, are you there?
I'm here.
Okay. Well, I was responding to David about, clarifying what happens in learning activities. And it's not just learning, it's the doing, the checking, it's the adjusting, it's the reporting, and all that would happen through the portal. And that, as you said, we think we have the opportunity to share those learnings and doings with others, and therefore to spread best practices both within organizations, for large organizations, and then across organizations. So that's the intent. And I know that the whole notion of learning community, learning collaborative, learning activity implies that this is class, but this is, this is doing. Okay.
So Peter, I wanted to address the question of the base amount real quickly. The rationale for that, group doesn't have to buy it, but the rationale is that there's a certain amount of overhead just associated with doing this project, and that if key managers and the like aren't tracking it and paying attention to it, that it has less likelihood of success. Well, the budget for Confluence, that might be budget dust, but for a really small outfit, and it probably isn't even for Confluence, Rick, but I run a relatively small organization, and there is some overhead. So the idea was that even the smallest outfit that's only doing one team still has a certain amount of administrative and other overhead, and that's arguably not too different from one organization to another. And so it's kind of establishes a base. That was the idea.
Are you looking for a vote on this, Peter?
I am on the concept. I want to, disassociate the actual amounts. I think we would have to come up with that. Sure. But I had a question from.
So there a question in the chat room.
Yeah. The question from the chat room said, as more of an independent rural clinic, we are more resource poor and do not have the infrastructure of large organizations that can facilitate teams. Therefore, Model 4 awards, I think rewards organizations who already have resources. Model 2 favors larger organizations. Model 1 and 3 are favorable to all players in the field. How do you propose to resource the small, independent, poor resource organizations? Well, I would say that
I think y'all do.
That's a good question. I think we're setting a minimum threshold for participation, and one of those thresholds is the ability to field a team. That if you don't have a team, you're not really participating in the learning activities. And I think that if you're a small organization who can field a team, you're still getting a base amount, and you're getting money to backfill your team, and that feels like it's scalable and still fair to the smaller organization. If you can't field a team, then I don't think you're playing. It doesn't mean you can't learn from it. It can't mean you can't observe. A lot of this will be public, but you need to have a team.
One thing too that's not shown here, it's not part of these figures, is that the ACH would be paying for help from CCMI CSI to operate these learning activities. So there would be that level of consultation. I'm not saying it would pay for every type of consultation an outfit would ever need, but that's a separate cost that would be supported by the ACH. So their involvement and guidance through the learning activities would be there for any organization involved, even the littlest.
So there's another part of this that I want to get to, which is the comprehensiveness and quality of the change plans. And before we ask for a vote, I just wanted to cover that as well. Caroline, if you could scroll up to that. We'd rolled this out to say, I think we have a duty to provide some oversight on how well these change plans are written to make sure that they cover the scope that was anticipated. And originally we had all, very complex scoring mechanism and questions about how we would tie funding to the scoring. What I think we're proposing at this point is that we still would like to evaluate plans for completeness, but it would be more on a a pass-fail sort of basis, and that we would use the criteria here to address quality and completeness, but there would be some sort of an evaluation process and an ability to get back to people to say, your plan's good here, but we think you need to embellish there. And the goal would be to get everyone to a place where they got full funding, but that we as an ACH would have done our due diligence to make sure that we felt these plans were comprehensive. And, one way to do that is to make sure that, everyone got to see everyone else's change plan. I know when I was in college and we graded each other's papers, that was the toughest grading I ever had, was my fellow students. So anyway, comments on that before we remember this is two elements, which is scope and scale, and then completeness and quality of the plan.
I think it's very important. Otherwise, we're not going to get the money from the state. So, I mean, we're the first stop here of proving what we're doing to the state.
And we might not have plans that really will amount to much. So
Do we, has the board come up with an amount of funding based on the change plan?
So, we have tossed around some numbers, and the plan at this point is to go to the board retreat, is that right, at the end of this month. We hope to present a global budget at that point, which allocates a certain amount of money to the Whole Person Care Collaborative and all the others. And right now, we have toyed with numbers that look somewhat like what you're seeing in this, in this table, that would probably live inside the envelopes that we're considering. But no, we don't have a global budget at this point. We're still working on it.
But we're trying to get there just as quickly as we can, given some uncertainty from HCA about details. It'll always be true.
So, yes. Is this Sheila?
This is Sheila, and I understand what staff has put forth as a recommendation in looking at page 42 of the packet. So I understand that the board, this would come as a recommendation to the board. It's very complex, and so maybe this is a question for Barry. We're not going to ask the board to approve this also today, are we?
Well, Sheila, I agree with you. It's very complex, and I really think the board, I'd like to ask them to approve the charter that this group endorsed, but I think it's going to take one more cycle to get to this level of detail, because as you said, it really would be difficult to understand what we were voting on otherwise.
Yes, I agree. That was going to be my comment. I think that the board needs to be able to have adequate time to review it, and then taking into account what David's question was, the board should be asking, well, based on this recommendation, how much exactly is this going to affect the budget? So those are critical questions for it.
Yeah, the way I've tried to summarize it is to say that you can't ask people to make multi-million-dollar decisions without knowing the fiscal framework for those decisions, and that's where we're trying to get. The board retreat will be a big step along that way, we hope. And then the February meeting perhaps would be a time when we'd be able to approve much of this.
So Sheila, this is advisory from this group, not on exact amounts, but on the funding philosophy, in the two, and how we would control for the two variables here. And, with enough information for you to see about how it might play out for your organization, without, exact amounts, but you get the idea. Comments?
So I would make a recommendation. I'd make a recommendation to approve staff recommendations on stage 2 funding as detailed on page 42 of that.
That's the one, by the staff recommendation. Yeah, we put that up. That's what we look at.
I do have one comment to add. This is Kim for Cape Motor Play. Before you move forward with it, can you hear me okay?
Yes, we can. Thanks, Kim.
That we're doing, because there's a certain amount of pay to play associated with this particular model, rather than outcomes-based payments or outcome-based result payments. I just want to give you a heads up or warning. I know that these amounts are hypothetical, but when I look at that chart, and right now there's a hypothetical $10,000 per learning activity, and it seems really high to me. If I consider that a learning activity might include, say, 7 to 8 organizations, you know, coordinating and sharing and trying to make something happen, depending on that learning activity, at that number, you know, you're looking at, you know, a $70,000 funding spread around organizations for a single learning activity. And so I would just model this just briefly as you look at numbers to understand how you could really drain a budget quickly with this model, depending on what that dollar amount turns out to be. You could conceptually you have your budget evaporate by getting people participating, but not necessarily knowing that you're getting the outcomes.
This is Barry, Kim, and they're great points. So I want to make 2 quick responses. One is that, yes, it is not paying for outcome. That's the structure of the demonstration. The data on the metrics that HCA is using won't even be available till 2019 or 2020. So they themselves understand that the whole thing is, when we say pay for reporting, it's another way of saying not paying for outcomes. So you're right about that. Regarding the budget, we are tracking that very carefully. And one of the issues that we discussed about some limit on the number of teams per organization goes to that. But we definitely are modeling that. And I think it's safe to say this work group now is the #1 priority for the ACH's demonstration projects, but we're concerned too that it could suck a lot of money in a big hurry if it wasn't structured right. So we are paying attention to that.
And Kim, I think you know, your point about not necessarily getting the outcomes. I think we would like to structure this work, you know, of the learning community, to give us the best shot at getting those outcomes. In other words, that the improvements we'll be working on, the things they'll be targeting towards, you know, should give us our best shot.
Audio. Can anybody hear me right now?
Yeah, we can hear you.
I can.
Yes,
I can.
Okay, so I think Molly answered the question for me. It really just boils down to, you know, approximately how, you know, for our 6 projects, approximately how many learning activities do you anticipate, and then the participating number, and then as long as your quote participation number, your participation dollars fits in that, you're fine. You know, as long as somebody doesn't go crazy with 1 million learning activities and, you know, everybody's participating in everything and you just kind of, you know, suck the bank dry, then I think the model still does work. It's just a matter of how much of a volume do you anticipate for learning activities and participation.
Yeah, we will model that to make sure it lives inside of our budget. So Sheila had a motion on the table for conceptual approval of the staff recommendation.
I'll second that, Malcolm.
So further discussion, points not made.
This is Amy. Just from a small organization perspective, how would you define team to participate? I haven't heard numbers.
Team would be a group of approximately 5 people who work together, including a clinical lead, a senior leader, and several frontline staff, probably maybe a mid-level nurse, an MA, you know, we can define that, but, you know, approximately 5 people in the same organization who work together in a clinical environment. So that's team. And we'll give you more specificity.
Peter, my question is, will the learning activities be let out, generated, run, whatever, by members of the learning community, you know, by providers or whatever, or will these be generated by the consultants we've asked to help us?
The learning activities will be agreed upon at the kickoff meeting. So the organizations that are participating, and we're about out of time. The agenda is, and Kathy, my apologies, we haven't got to this, but the goal of the kickoff meeting is essentially to define the learning activities that people would participate in. And this is just for stage 1, okay? I mean, this is just to get going, because we will go through many, many cycles of this over the next 4 years. You know, presuming that this is effective, we get better at it. There will be lots of opportunities to continue to weigh in on which learning activities and how many teams people want to participate. So
I think part of David's question though was that, you know, is it just members of the group or just kind of grouped together and let go, or is there more structure and leadership provided? And my understanding is that CSI provides structure and leads each learning activities process based on evidence-based experience from the past. So it isn't just a free-for-all.
Kathy, can you comment on that, please? I mean, your role in leading this is hugely important.
Yeah, that's absolutely right. And so we want the participants, the learning community, to define what it is that they need most. And then our role as consultants is to provide that structure and to find the necessary resources, either within your region or external to your region, to help you with the transformation. So that what was said was absolutely correct.
So you collectively define it, and you know the groups may segment into peer groups depending on what people most want to work on. I think behavioral health will probably be their own community to some extent, but that's what we want to define together.
And then the other thing, as the work group is going along, we're also going to observe some areas where the transformation and where the performance perhaps is lagging. And so they might determine that a learning activity is recommended in certain areas based on the progress of the work over time.
Okay, so we're about out of time. We've got a motion on the table. I think we heard a second from Malcolm. And if there's no further discussion, Blake, did you want to say something?
And the chronic disease project, and that the learning community would be part of supporting that. So these learning activities, folks have been referencing supporting 6 projects. Are they only supporting those 2 projects?
They're supporting all 8 of those.
Main plan components.
Right, and how we address those over time will be determined. So we're talking about funding philosophy here. So if I could ask for a vote, all in favor of what's been moved and seconded, say aye.
Aye.
Aye. Opposed?
Aye.
Aye.
Opposed?
Okay, opposed. I don't know.
Opposed. Okay, we got 2 opposed. And any abstentions? Okay, I think the motion is carried, and I want to hear more about the opposing points of view. And at this point, I think we do need to adjourn because we're over time. And Kathy, my apologies to you. For all of you, we do have the proposed agenda for the first learning activity, which will now hopefully be in March, in your packet. So this will give you a sense of what's involved there. So thank you very much for your time and your patience, and see you later.
Thanks, everyone. Bye.